Hello, I'm Robert Hinchliffe, editor BJS British Journal of Surgery. A happy new year from the editors and staff at BJS, and welcome to the January 2017 issue Editor podcast. The new year will usher in a number of initiatives that are all part of a plan to expand the global reach of BJS and to provide a dynamic surgical community with information, research and comment. Recruitment of patients into surgical trials is difficult. 1 in 5 surgical RCTs is discontinued early and 1 in 3 trials remains unpublished. What is the best way to recruit and randomise patients within established RCTs? In their leader, Treasure and Baum offer a number of solutions, including the argument that perhaps surgeons might only meet patients once they have been randomised to surgery. One of the best ways to ensure that appropriate RCTs are conducted is to perform a well-constructed pilot trial to establish feasibility, including the refinement of endpoint definitions and estimation of potential effect sizes. In this month's BJS, one such trial comes from an Edinburgh team, including the late Professor Ken Fearon. They performed a phase 2 study to test the hypothesis that combined oxycodone-naloxone preparations may reduce opioid-induced postoperative gut dysfunction. This study examined the feasibility of a randomized trial within the context of a laparoscopic colorectal resection. In the second RCT, members of the Dutch Diverticular Disease Collaborative Study Group randomized some 528 patients with CT-proven uncomplicated acute diverticulitis to antibiotics or observation in 22 Dutch centres. The results certainly challenge surgical dogma. And we continue with the diverticular theme in the January issue, this time with an economic analysis of the ladies' trial, comparing laparoscopic lavage with sigmoid resection for perforated diverticulitis. Their findings appear to confirm that lavage is cheaper than resection, taking into account the need for surgical reinterventions or stoma reversal. There are yet more data from the West Midlands Research Collaborative, this time confirming, as many of us will have suspected, that emergency laparoscopic cholecystectomy is cheaper and more cost-effective than delayed laparoscopic cholecystectomy for acute gallbladder disease. The challenge, I suspect, will be for hospitals to meet the demands required to investigate and treat patients promptly on the same admission. However, these data do help justify the resources required to meet that challenge. Most surgeons now routinely use laparoscopic surgery for much of their practice. But if you are going to perform laparoscopic surgery, is there really any benefit from a single port incision? An international multi-centre registry of some 1,700 patients, with about a half undergoing surgery for malignant indications, was reported. The authors highlight particular situations that appear to confer worse outcomes with this technique, but overall they found outcomes similar to established multiple port procedures. Finally, they call for well-constructed randomised trials to allow a definite conclusion regarding the most appropriate approach. However, I suspect these may happen, but I find it hard to believe that a single incision will not become routine once the technology evolves. The systematic reviews and meta-analysis have a surgical education and training flavour this month. Goldenberg and colleagues from Toronto scoured the surgical literature to identify standard-setting methodology to establish a performance standard in technical skills. They provide an excellent overview of the current approaches used, including item-centred, participant-centred, and procedural-based methodologies. Considerable variations in outcomes are a common problem in surgery and prevent meaningful interpretation of the value of surgical techniques and technology. One of the reasons might plausibly be due to major differences in surgical training. Elsie's review in this issue highlights some of the fundamental problems with respect to training. Specifically, there seems to be significant variation and poor recording of the numbers of operative cases performed by general surgical trainees between different countries. How do you manage patients with lymphedema? Well, most surgical interventions carry significant morbidity and have largely been abandoned, and compression therapy has become the mainstay of treatment. Lamprou and colleagues present in this issue their outcomes with a new technique of circumferential suction-assisted lipectomy. They impressively reduce the limb volume in patients with this new procedure, both for patients with primary and secondary lymphedema. However, it will be interesting to see the longer-term outcomes after 2 years and the effect on patients' quality of life. Nevertheless, this appears a very promising technique. In this issue, there are also key data from Heidelberg on the importance of chyle leaks after pancreatic surgery, some data on the outcomes of inguinal hernia repairs in children, outcomes for hepatocellular carcinoma and neuroendocrine tumours. January sees the launch of BJS Open, a new journal in the BJS stable. It has been developed to offer publication to the ever-expanding number of acceptable and valuable manuscripts that are submitted to BJS. Transition from BJS to BJS Open will be made possible through a straightforward editorial process in Scholar One and overseen by Professor Derek Alderson. Expect to see more developments in BJS over the coming months, including improved interaction with social media. Don't forget to look out for a free BJS special issue on surgical infection, which will appear in mid-January on the New Look website. It really is relevant to all surgeons, no matter what your background, and includes an analysis of established therapies and those appearing on the horizon that promise to change the way we practice. So that's it from me. Wishing you all a happy, healthy and successful 2017.